Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. In the last previous class, we have discussed the most of the important questions concept by holding the one particular questions. We have discussed around the near 10 to 5 to 10 questions in every question with a clear concept and rationale. And I have given some assignment to you people, and many of you have responded to the assignment very beautifully. So that shows your interest in the learning and practicing the good content. Yes, that actually boosts and motivates me to take that kind of the steps towards you people to make you engaged in the learnings, right? So very good evening to one and all once again. Good evening, beta. Very good evening. Good evening. Good evening. Very good evening to one and all. Welcome once again everyone to the master nursing classes. If any one of you watching the classes first time, so please do subscribe to the channel, hit the subscribe button and press the bell button beside of the subscribe button if any classes in the future and further, so that will get notified to you people on the time, right? And if you found the previous classes and today's classes helpful to you people, so don't forget to hit the like button. Your one like matters us a lot, right? So without wasting any further time, we will start the today's class. Yes, almost all many of you have joined the session. So we will start now with this wonderful motivational line for you people. Students in your life, never ever and don't blame the distractions. Just try to improve your focus, because if you are working to improve your focus means the distractions will automatically goes beside. There is no need to do extra for your improving the focus. Just try to be engaged in your good work, engage in your study, so that automatically uh, bypasses the all kind of the distractions, right? So hope every one of you have ready to the class. So now we will start the class. Okay, so I have given one assignment yesterday, so to identify the image of this particular very important A, okay, and this one B image, okay, half body is pink, half body is pale or blue. So I have asked the name of this particular two important sign here. So this is the normal finding which will be seen in the newborn. That's the bluish discoloration at the sacral area. So that is what we call as the Mongolian blue spot. Okay, so and here half body is pink and half body is pale or blue. So this one what we call as in the Harlequin sign. And I have given the very important assignment to you people on the Gower sign also, right? Gower sign is classically seen in which of the following condition? This is the very important and hot topic, repeatedly asked in the previous INA CET exams, and one time asked in the Norcet also. So I want to repeat you all the golden points in the Gower sign and Duncan muscular dystrophy here. Okay, many of you have commented on the correct answer. That is the Duncan muscular dystrophy. So this is the correct answer. Gower sign is classically seen in the Duncan muscular dystrophy. What is the Gower sign? What is the Gower sign? Yes, the Gower sign is due to the muscular weakness. The boy who is in the sitting position, he wants to stand means he can't stand directly. He will take a support of the floor, then he will get stand half, then he will take a support of the knee, then he will stand fully. Okay, so there is excessive muscle weakness that makes the child to unable to stand independently. Okay, so he will usually takes the help of the floor. Okay, and he will take the help of the knee to get stand. Okay, that is the Gower sign, which happens due to the muscular, yes, which happens due to the muscular weakness in the Duncan muscular dystrophy. We will discuss all the questions, and very beautifully our aspirant she commented all the correct answer. That is the given image B is the Harlequin. Yes, that is the correct. And given image A is the Mongolian blue spot. Yes, B is Harlequin, A is the Mongolian blue spot, and the third assignment C is the our Dengue muscular dystrophy. Okay, this is the correct answer given by the Pooja Mogar. Okay, our aspirant, the MNC students, she given all the correct answer, right? So hope it is clear to everyone. And let me discuss all the golden points on the uh, our very important Duncan muscular dystrophy. This is usually a genetic disorder. The Duncan muscular dystrophy is a genetic disorder which is caused by the mutation of the DMD gene. That is the Duncan muscular dystrophin gene. Okay, so on the X chromosome, and this is the XLR disease. Okay, this is the XLR disease. What is XLR? It's in short tricks to remember for the X-linked recessive disorder. Okay, so the question will come. The Duncan muscular dystrophy is the X-linked recessive disorder. Okay, very important due to the mutation of the DMD gene. The classically very importantly the question will come: which protein will get deficiency in the Duncan muscular dystrophy? Yes, the dystrophin protein is absent in the or severely deficient in the Duncan muscular dystrophy. The protein name, they will ask in the exam the name of the protein which will get deficit in the Duncan muscular dystrophy. The name of the protein is the dystrophin protein. Is the severely deficient or it is completely absent in the muscles. Sir, what is the function of the dystrophin protein? Bacho, dystrophin protein is the protein which is responsible to maintain the integrity of the our muscular system. When there is a lack of the dystrophin protein, that time there is no any integrity, means there is no any strength in the muscles. So there will be a chance of weakness of the muscles, which will be classically seen in the Duncan muscular dystrophy. Because of the weak muscles, the patient will manifest with a Gower sign here. Okay, the patient will manifest with a Gower sign. Means the child uses the hands to climb up or the legs to stand. Right. I have told you people the child uses the floor for the standing up, and he will uses the legs. Means he will. Keep the both hands on the knee, and then after that he will get stand. Okay, like this was what we have discussed on the Gower sign already. Okay, so very important. And early sign of the Duncan muscular dystrophy is the delayed walking, and frequently like child will fall. Okay, then the waddling gait will be seen in the uh, our Duncan muscular dystrophy. There is no any normal gait. Okay, so the waddling gait means the child will move like this while walking. That's what we call as the waddling gait, right? So very importantly, you people have to know here. Then the severe muscles weakness will be there. So muscle weakness starts from the proximal muscles, that is from the hip and shoulder. Okay, from the hip and from the shoulders. From there, the muscle weakness will start. Okay, so in the Guillain-Barré disorders, the muscular weakness will start from the distal. Okay, from the foot it will come up. Okay, that is what we call as in the ascending paralysis. We will see in the our Guillain-Barré syndrome. Okay, here in the Duncan muscular dystrophy, the muscle weakness starts from the very proximal muscles, and which will begins from the shoulder and the hip. Very important. Okay, so then comes to the progressive muscle weakness will happens, and there is a laboratory value which increases in the Duncan muscular dystrophy is the creatinine kinase. Why it will happens? Yes, whenever there is the damage to the muscle fibers and muscles, so from the muscle fibers and muscles, two things will release. One is the myoglobin, and another one is the creatinine kinase. Okay, so here due to the lack of the integration of the muscle fibers, so the creatinine kinase will increases. Okay, very important, especially creatinine kinase CKMM will increases in the our Duncan muscular dystrophy. Very important point. Okay, so diagnostic purpose we have to take the muscle biopsy. Okay, so here we have to take the muscle biopsy. In the muscle biopsy, there is absent of the dystrophin protein, and severe deficiency of the dystrophin protein will be classically seen here. Okay, so then the genetic testing also will do for the X-linked recessive disorder. Okay, so the cause of the death in the muscular dystrophy, Duncan muscular dystrophy, is the cardiac and respiratory failure. One you want to do answer means there is the cardiac failure due to the cardiomyopathy. Okay, due to the cardiomyopathy. Okay, so due to the cardiomyopathy, there is the death in the Duncan muscular dystrophy. All the golden points on the Duncan muscular dystrophy we have seen. Consider, bacho, this is the very important 5-star topic for your upcoming Norcet exam, GMCH exam, KGME exam, and all the state government and central government nursing officers exam. The most important point. Okay, so hope it is clear to all of you. Right. So here is the next question waiting for you people. Please try to respond to the every question what I am trying to ask here. And in the yesterday's class, you people given the very huge and best response to all the assignment what I have assigned to you people. So that shows your interest in the learning and which actually motivates me to get take class regularly, right? So this is the question in front of you people. Nagayama spot are most commonly associated with which viral illness? So what is the Nagayama spot? Nagayama spot is a red color rashes which will be seen on the our hard palate here. Are you people able to see a red rashes here and on our uvula? Okay, so on the uvula and on the hard palates there are red color rashes. Okay, so this is what we call as the Nagayama spot. This particular area, what we call as the Nagayama spots, which is looking like a snake. Okay, for remembering purpose, I am showing you people. Okay, so in the on the uvula and on the hard palate there is rashes which looking like a Nagayama spots. Okay, which is a classically seen in which of the following condition? Option A, rubella. Option B, roseola infantum. Option C, hand, foot, and mouth disease. Option D, measles. So I want fatafat answer in the comment box. So everyone who all are live to the session, whether your answer may be a right, whether your answer may be a wrong. So try to include your answer in the comment box, right? Very nice of you all. Okay, almost all of you have given the correct answer. That is the roseola infantum. In this particular case, we will see the Nagayama spot. Very importantly, it will come in your exam. Okay, so let me quickly revise the all the golden points on the roseola infantum. Roseola infantum is a viral illness. Okay, so happens due to the human herpes virus number 6 or 7. The most common one is the human herpes number virus 6. Okay, so very important. So this roseola infantum is also called as in the sixth day disease, right? Very important. So it begins suddenly and a high grade fever will be there which lasts for the 3 to 5 days with without any prominent symptoms. Okay, so that is the very important. There is a high grade fevers will be there, but the child who's undergoing the human herpes virus number 6 infection, so he will like there is a excessive high grade fever also will be there, but child is looks like normal only. Okay, so that is the very important. So high grade fever will be there for 3 to 5 days without outer prominent symptoms, and the child who is getting this infection, he will looks like normal only. Okay, so as the fever abruptly resolves, the rose pink maculopapular rash will appear. So starts from the trunk and spreading outward. Okay, so there is the not important, just consider the point. Okay, so when the rashes will appear, when the fevers decreases, that time the rashes will appears. Okay, so fever decreases, rashes will appear. This is the classically seen in the our roseola infantum and starting from the trunk and spreading the outward. Okay, that is what you call as the centrifugal rashes, right? So centrifugal rashes means it will spread from the center to the periphery. Okay, so that is the most important thing all of people have to know and understand. Okay, so the next one is the Nagayama spots is the classical spots. So we'll see on the soft palate, hard palate, and uvula. Okay, yes, on the hard palate also we will see this one. Soft palate also, and on the hard palate also, and on the uvula also, you will see the Nagayama spots during the febrile period. Okay, means whenever there is the fever in the roseola infantum, so at that particular time only this Nagayama spot will be seen. But rashes on the body happens when the fever will get decreases. Okay, so child will remain active only, child will playful only, and despite of the high fever, still the baby is having the high fever, he will be active only, and the child will play engaged in the activities, and he is fit to play the all the activities. Okay, so this is classically seen in the or roseola infantum. The thing to remember here is that it's a viral illness caused by the human herpes virus number 6 and 7. The most common one is the 6, and there is high grade fever, but still the baby is normal only, and rashes appears in the trunk and which spreads to the periphery. When the rashes will happens, when there is then the a decreased fever, then only the rashes will increases. Okay, so the Nagayama spots will be seen on the soft palate, hard palate, and uvula. Okay, so that is during the fever period only. Okay, and child is having the high grade fever, still he is okay normal, and he is playful and active only. Okay, so this is the classical findings we will see on the Rosier infantum. And so hope the answer is clear to you people on the Nagayama spot. Okay, so hope it is clear. And here is the beautiful advertisement for you people for a 30-second. Yes, the Norcet 9 Navagraha test series is live in the Master Nursing Classes app. So if you want to become a part of this very very wonderful platform test series, the India's best test series, which including all the updated questions, important questions, questions with the clear rationale and concept, and the questions which will strike in your upcoming Norcet exams. This is the wonderful and very very wonderful platform for you people. And here you will get the daily live test from morning 6 a.m. to the 11 p.m. At the 11:30 p.m. you will get the all India rank. Along with that, you will get the weekly booster class, which will including the making the very complicated topics to very very easy to the aspirants to get a best rank in the upcoming exams. Okay, so along with that you will get the 24 hour into 7 chat box support and the doubt clearance session by the experts. Okay, so the very very important thing, that is the Narset 9 Navagraha test series, a course for the good rank. So if you want to be a part of this one, so do download the Master Nursing Classes app. The link is there in the description box and the link is there in the comment box also. Okay, so hope it's clear to every one of you. And here is the next question. Yes, very simple, very very important question. The current jelly sputum is a characteristic finding in pneumonia caused by. So this question will be definitely strike in your exam. It may be comes in the form of the scenario, it may be comes in the form of the single liner. Okay, so I will tell how it may create with the scenario. Okay, there will be a scenario given like this: the 30-year-old male who is having the cough. Okay, and he will tells that there is he is getting the current jelly sputum. Along with that, there is then the mild fever also will be there. Okay, so and shortness of the breath and saturation started to decrease. Okay, so which of the following may be a causative organism we will expect, bachon? The Streptococcus pneumonia is also responsible for the pneumonia. Pseudomonas aeruginosa also responsible for the pneumonia. Klebsiella also responsible for the pneumonia. Legionella also responsible for the pneumonia. Here, in all the pneumonia, you will get the shortness of the breath. In all the pneumonia, you will get the fever. In all the pneumonia, you will get the desaturation and consolidation of the lung. Okay, but the differentiating feature is the, yes, the color of the sputum, which helps you to identify the correct answer here. Okay, so here we will see the current jelly sputum as a characteristic finding in the pneumonia. Okay, option A is telling that is the, yes, a streptococcus pneumoniae. In the streptococcus pneumoniae, okay, so we will get the rusty color sputum or the rust color sputum. So this is not our answer. Okay, in the streptococcus pneumoniae, okay, so which will be a classical and very important and most common cause of the lobar pneumonia. Okay, so there is a streptococcus pneumoniae. So in this condition, we will see the rust color sputum. But the question examiner asking the question, that is the current jelly sputum, which is a classically seen in the Klebsiella pneumonia. Okay, which is oftenly associated with the alcoholic patient. Okay, so when there is a patient comes with a chronic alcoholic with the pneumonia and the red current jelly sputum, so not the red current, so there is the current jelly sputum. So that is the classically seen in which condition? Yes, due to the which organism? That is due to the Klebsiella pneumonia. Okay, so here the question is simple: current jelly sputum is characteristic finding of the Klebsiella pneumonia. Okay, so this goes to the correct answer here. And in the streptococcus pneumonia, we will get the rusty color sputum. And in the Pseudomonas aeruginosa, wherever there is a question on the Pseudomonas, always choose the green as a correct answer. Okay, so due to the vaginitis, due to the Pseudomonas, again the green color discharge will come. Okay, so the sputum due to the means pneumonia due to the Pseudomonas aeruginosa, again the green color sputum it will come. Okay, so that's the very very important. Always try to choose the answer as the green in the Pseudomonas. Okay, so that is green in the Pseudomonas aeruginosa. Okay, right, hope it is clear. And let me quickly revise all the color and the very very important associated conditions. Okay, if the patient is getting the rust color sputum with all the signs symptom of the pneumonia, your answer should goes to the streptococcus pneumoniae. This is the classically and most common cause for the our lobar pneumonia. Okay, and in your question there is a current jelly sputum. The answer goes to the Klebsiella pneumoniae. And in your question there is a green color sputum. The answer goes to the Pseudomonas aeruginosa. And in your question the yellow color sputum. The answer goes to the Staphylococcus aureus. Okay, if the sputum is foul smelling, that may be due to the anaerobic infections, and that may be due to the aspirational pneumonia. Means, so if any content we have aspirated during the having the food or doing the regurgitation or doing the any kind of the procedures, if there is any aspiration of the content which goes into the trachea, at that time the sputum will come with a foul smelling sputum. Very very important. And this is a pink frothy sputum. This is very very important. Pink frothy sputum you will see in the pulmonary edema. Okay, so when the pulmonary edema will happens, pulmonary edema will happens during the left side of the heart failure. So that time we will get the pink frothy sputum. Very very important. Okay, so I will give the 5 star to the pink frothy sputum. There is highest chance of asking the question. Okay, so and I will give the 5 star to the rusty sputum. So there is highest chance of the asking the question because which is the most common cause. Okay, so then I will give the 5 star to the our current jelly sputum. Okay, so these three are very important. And if you are fit and fine to remember all other things, so that is very much useful, and that decides your rank. Okay, so hope it is clear to everyone. And at the end of the session, you people have to answer and comment to this particular question. This is the assignment of the day. Okay, where we will get the red currant jelly stool. Okay, so just we have seen that's the red currant jelly sputum. Okay, not red currant, just an currant jelly sputum we have seen in the yes case of the Klebsiella. Okay, so in case of the Klebsiella we have seen that is the uh, that's the current jelly sputum. But the question here is the current jelly stool. Okay, so red currant jelly stool where we will see. And strawberry tongue we have seen in the two cases. One is the strawberry tongue in a Kawasaki disease. Okay, another strawberry tongue in the yes scarlet fever. Okay, the next question is the strawberry color vagina will be seen in which of the following which of the condition. Okay, so that one you have to comment in the comment box. Okay, then the spoon shaped nail. Okay, so this spoon shaped nail also where we will seen as a classical finding. Okay, so I want answer to these particular questions. Again, how I have taken the name of the aspirant in the today's class, who have given the correct answer in the yesterday's class. So same thing I will take your name with your correct answer in the next class if you have given the properly correct answer. Okay, so the red currant jelly stool and the strawberry color vagina and spoon shaped nail. So on this one there is the A, B, C. Just you have to mention the answer. A in front of A answer, B in front of B answer, and C in front of C the correct answer. Okay, who will give the correct answer? I will take the name of that aspirants in the next class. Okay, so here is the next question for you all. Yes, Fataфат, try to answer in the comment box. Which of the following pneumonia causing the organism lack of the cell wall and thus does not respond to the beta lactam antibiotics? Student, there is the one bacteria which is not having the cell wall, and beta lactam are the antibiotics which acts on the cell walls and which inhibits the synthesis of the cell wall, right? So if we are giving the antibiotics, that is the beta lactam antibiotics, it is only effective against the bacteria who is who all are having the cell wall. Okay, the bacteria where there is no cell walls, there the beta lactam antibiotics will not work. Okay, the classically we'll see in the penicillin, amoxicillin, these are the classification of the beta lactam antibiotics. Okay, so there is cause of the pneumonia, that particular causative organism is not having the any cell wall, and that particular causative organism will not respond to the beta lactam antibiotics. I want the answer for the that particular very important causative organism which is not having the cell wall and not response to the beta lactam antibiotics. Option E, streptococcus pneumoniae, which is having the cell wall, and Klebsiella pneumonia, which is having the cell wall, and Haemophilus influenza, which is having the cell wall, and Mycoplasma pneumonia. Yes, many of you and some of you have given the correct answer. That is the Mycoplasma pneumonia is the bacteria which is not having the cell wall, and so which is not responsive to the beta lactam antibiotics. So our correct answer goes to the option C here. So that is the very much correct answer. Hope it is clear to you people, right? So I think it's clear. Just we will see the very important questions also. And this mycoplasma pneumoniae is the most common cause for atypical pneumonia in pediatric. Very important, bachcho. The most common cause of the pneumonia is the different. If the examiner is asking the most common cause of the atypical pneumonia, that is our mycoplasma pneumoniae. Sir, what is the difference between the typical pneumonia and atypical pneumonia? Let me explain. The typical pneumonia means the infection of the lung parenchyma happens, and it will show the all the classical signs like shortness of the breath, like sudden drop in the saturations, like fever. Okay, there is a high grade fever, and the uh, organism associated with sputum, so it will manifest. Means, however, the clinical manifestation of the pneumonia which is written in the book, the all the clinical manifestations similarly comes in the typical pneumonia. Okay, but the pneumonia happened, but it is not showing the classical sign symptoms which is given in the book. Okay, so still the infection is happened to the lung parenchyma, and there is in the pneumonia is there, but which is not showing the all the classical symptoms of the pneumonia. So that is what we call as in the atypical pneumonia. But one very important thing on the pneumonia we have to see, if there is in the typical pneumonia or the pneumonia, so that time entire lungs will be consolidated. Okay, so when we will see the chest x-ray of the pneumonia patient, the lungs are consolidated due to the accumulation of the pus in the parenchyma of the lung. Okay, but that same thing when you will see the x-ray of the atypical pneumonia, there is no any consolidation, which looks like a interstitial infiltrations and interstitial diffusion, which looking like that. Okay, but the actually classically we will see in the pneumonia, that is the consolidation of the lungs. But in the pneumonia with consolidation of lung is not there, so that is then the atypical pneumonia. Okay, it means it will not show the actual sign symptoms which is written in the book. Okay, so hope it is clear to you people, right? So let me differentiate and understand the very important questions and concept on the typical and atypical pneumonia. So the onset of the typical pneumonia is the sudden and acute, but the onset of the atypical pneumonia is the gradual and insidious. Okay, so the very important, the most common cause of the typical pneumonia or the pneumonia is the streptococcus pneumoniae. Okay, so the most common cause for the atypical pneumonia, most common cause for the atypical pneumonia is the mycoplasma pneumoniae. So it's the most common cause for the our atypical pneumonia. And there is question in the INSCT, which of the following is the causative organism not associated with the atypical pneumonia. Okay, so that question may strikes in our upcoming Norcet also. Okay, so that is the very important, mycoplasm and chlamydia and legionella. So the pneumonia happening due to the mycoplasm, chlamydia and legionella, that is the MLC. Okay, medico legal cases. Okay, so that is the mycoplasm, legionella and chlamydia. So due to the infection of these particular three very important bacteria, the lung parenchyma is infecting, means there is no classical sign of the pneumonia will come, means all these three are responsible for the causing the atypical pneumonia. Okay, so the streptococcus pneumonia, if the pneumonia happening, means all the classical sign of the our pneumonia will comes here. Okay, so that is the most important, right? So the most common cause of the typical pneumonia is the streptococcus pneumonia, and atypical pneumonia is the mycoplasma pneumonia. Hope the concept and question is clear here. Okay, so then comes to the other causes of the typical pneumonia. There is the Haemophilus influenza, and Klebsiella is also responsible for the typical pneumonia. Okay, so when you will see the cough, the classically in the pneumonia, the productive cough will come with a purulent sputum. Okay, so different color sputum, like the pneumonia due to the Klebsiella means the current jelly sputum will come. Pneumonia is due to the streptococcus pneumonia means the rusty sputum will come, and pneumonia due to the other conditions like Pseudomonas aeruginosa, the green color sputum will come. Means in the typical pneumonia or the pneumonia, the productive cough will come with a different color of the sputum, as depends on the causative organism. Okay, but in the atypical pneumonia, there is only dry cough will be there, and the non-productive cough will be there, means which is not a classical sign of the pneumonia. So that is what we call this one as the atypical pneumonia. Okay, so when we will see the fever, so fever will be high grade in the typical pneumonia with chills, And in the atypical pneumonia, there is low grade fever often without any chills. Okay, so that is the very very important. And when we will auscultate the lungs of the patient of the pneumonia, there will be a crackles and the bronchial breath sound will be heard over the, yes, the lung fields. Bacho, very very important. Bronchial breath sound will be heard over the, yes, our very very important trachea, right? If the bronchial breath sound we are hearing over the lung fields, okay, so normally bronchial breath sound will be here, okay. If the bronchial breath sound will be hearing over the lung fields, means which will be indicating that the pneumonia, okay. Usually on the lung fields the vesicular breath sound will be there. Yes, usually on the lung fields normally vesicular breath sound will be there, but there is absent of the vesicular breath sound, and the bronchial breath sound we are hearing on the normal lung fields, means that indicating the pneumonia, okay. So very very important in the auscultation in the typical pneumonia or in the classical pneumonia, so we'll get the classical and the bronchial breath sound on the lung fields, okay. Very very important. And in the atypical pneumonia there is no any crackles, there may be a minimal crackles we can see, okay. So that is the atypical pneumonia, okay. The very very important thing which will strike in your upcoming exam, consider this one as in the 10-star chart for your exam, okay. Hope it is clear to you people, right? So here is the next question for you people. So fatafat, do read the question concept and try to get the best answer. I'm waiting for your response in the comment box, bacho. Very good. Yes. A newborn presents with a cyanosis that worsens during the feeding and improves when the baby is crying. What is the most likely diagnosis? What happening here? The newborn is there. They came to the hospital and the mother is complaining now that when the baby start to feed, that time the baby will land into the cyanosis, means the bluish discoloration happens. And when the baby will start to cry, that time the baby cyanosis will reduces and the baby's body become pink, means during the feeding the baby will getting the cyanosis, during the crying the baby is getting the pink color, means the good oxygenation. So what is the most likely diagnosis of this particular very important question here? Yes. Option A, laryngomalacia. Option B, choanal atresia. Option C, tracheoesophageal fistula. Option D, crop. What is the answer? Yes, in the crop we will see the barking or the seal-like cough due to the laryngotracheobronchitis. So here we will not see the our very very important scenario which is given here. Okay, I am eliminating the crop here. Okay, so then the tracheoesophageal fistula with esophageal atresia, that time we will see the a triple C sign, that is the cyanosis, coughing, choking during the feeding. When that is the during the feeding, okay, if the mother tried to feed the baby, okay, that time the cyanosis will be there, coughing will be there, choking will be there, okay. So that is we will see in the tracheoesophageal fistula with the esophageal atresia, okay. So that is most common. And in the laryngomalacia, okay, in the laryngomalacia, if we give the supine position to the baby, that time the larynx will completely blocks the trachea, and that time the cyanosis will happens, okay. During the supine position the cyanosis is happening. When we will give the prone position to the baby, that time the cyanosis is decreasing. That is the classically seen in the laryngomalacia. Here the given scenario, there is the newborn with cyanosis that happening during the feeding, okay, improves with crying, means this is the classically seen in the choanal atresia. So what is the choanal atresia? There is in the posterior pharynx, in the posterior nasal pharynx, there is a excessive bony growth or the membranous growth which blocking the nasal airway. Okay, so here the the baby normally in the person, okay, so this is the nose and this is the nasal airway which is completely clear where the air is going into the trachea, okay. So this is the oral airway which is completely clear, the air will go into the trachea, okay. So this is the normally what happens. But in the choanal atresia case, the bone will be excessively grown here, and when the baby try to take the air, it will not go into the trachea, okay. So the air will limit only to the nasal cavity, okay, like this much only. So When the baby is start to feed now, that time the oral airway is also closed and nasal airway is also closed. Okay, when they're during the feeding, the oral airway is also closed and the nasal airway is also closed. So during the feeding, there is chance of the sinuses. And when the baby tried to cry, so I think you people have seen how the baby will cry. The baby will cry with by opening the mouth. Okay, so if the baby is crying with open mouth, that time the air will enter, so that time sinuses will decreases. So this is the classical scenario of the clinical based question which may manifest in front of you in your exams. Okay, so I think it's clear to you people. Okay, so now the answer goes to the coronal atresia. The cyanosis happens during the feeding due to the block of the both oral and nasal airway, and the cyanosis will decreases or the condition will improve with open mouth or during the baby crying. So that goes to the correct answer. That is the coronal atresia. Okay, very very important, bacho. And one more very important question it will be asked on the coronal atresia. So let me discuss that question also. Okay, so here is the next question. The next question. What is the initial test to confirm the coronal atresia in the newborn? What is the initial test we have to perform to confirm the coronal atresia? The CT scan of the head and neck is the CT scan of the head and neck is the a definitive diagnosis. Okay, or we can say the confirmed diagnosis. Confirmed diagnosis. Or we can say the definitive diagnosis, which is not an initial. Okay, which is not an initial. So I am eliminating the option C. So CT scan is not answer because there is an initial test to confirm clinically the coronal atresia. Okay, so the initial test what we have to do, we have to take one NG tube and we have to try to push the NG tube through the oral cavity. It will enter till the stomach. Yes, there is no any blockage in the oral cavity. Usually it will enter into the stomach. Okay, so take the NG tube and push through the mouth. It will enter into our stomach. But same NG tube, when you will try to push from the nose, it will not enter. Okay, so this is how we will confirm the coronal atresia. Okay, so attempt to pass the catheter through the nostrils, so which blocks. Okay, so if you are entering the this particular any catheters or the NG tube through the mouth, it will enter into the stomach. If you will try to insert the NG tube through the nasal cavity, it will not go into the stomach. So it will blocks in the nasal cavity only. So that is the very very important thing as a clinical based scenario question which will be comes in front of you on the coronal atresia. Okay, so similarly, so there is then the one more questions on the tracheoesophageal fistula with esophageal atresia will come. But in the both situation, like this is the oral cavity and this is the nasal cavity, and so this is the esophagus. Okay, so here it will be connected with this one, right? Also, okay, so here the tracheoesophageal fistula with esophageal atresia means there is in the block in the normal connectivity of the esophagus. That time when you will try to insert the NG tube through the nose, it will go the half and it will coil here. And when you try to insert the NG tube through the mouth, it will go half and it will coil here. Okay, so similarly, means not similarly here in the tracheoesophageal fistula with esophageal atresia, there the half of the length of the NG tube will go both the cases when you will insert through nose, when you will insert through mouth, and there is a coiling of the tube happens here. But in the nasal coronal atresia, the oral insertion it will go till the stomach, and when you try to insert from the nose, it will block in the nose. This is the very important and classically differentiation what you have to make during the exam. Okay, so that is hope I think it's clear to every one of you, right? So that is the important question I have shown to you people. Okay, so hearing again the very important clinical and scenario based question waiting for your response here. Fatafat do comment the correct answer in the comment box. Yes, I'm waiting for your response. A newborn with the inspiratory striders shows the improvement in breathing when the placed in prone. Which condition is most likely? What happened to the newborn here? The newborn is having the strider. What is the meaning of the strider? Strider is the a sound which happens during the respiration due to the narrowing of the upper respiratory tract. When the strider will happens due to the narrowing of the upper respiratory tract. This is a very important point you have to remember. Okay, the baby is now manifesting, the newborn is now manifesting the stridor during the inspiration and shows the improvement in the breathing. Means when we place the baby on the prone position, when we place the baby on the prone position, there is the improvement in the breathing. Means there is a normalization. Normally, baby will be breathe. Okay, so which condition is most likely is this? Option A, corneal atresia. No, in the corneal atresia, just we have discussed when the baby is feeding, that time cyanosis will happen. Baby is crying, that time the cyanosis will resolve to the normal. Okay, so that is in the corneal atresia. Okay, so not like this. Option D, we have discussed that the barking and seal like cough we will see in the cough due to the tracheolaryngomalacia and stipple sign we will see in the, yes, in the crop. Okay, so that is the very important due to the subglottic narrowing of the our what we can say, that tracheal windpipe. Okay, that is the stipple sign we will see. Okay, so then the next, tracheoesophageal fistula. Yes, I have discussed all the X-ray signs of the respiratory tract and its disorder in the separate video. That's in the X-ray video. Okay, so all the clinical very important questions with the very basic of the how to read the chest X-ray in the tension pneumothorax, cardiomegaly. Okay, what is the cardiophrenic ratio? What is the everything on the X-ray we have discussed in detail. There is one separate dedicated video on that one. Okay, so if you want to if you want to watch that one, you can watch. Okay, so type X-ray by the master nursing classes, you will get the video. Okay, so then you can watch that one at the end of this particular very important class. Okay, so then comes to the next very important option here. There is the tracheoesophageal fistula. Yes, in the tracheoesophageal fistula, as I already told, the three signs during the feedings, that is the cough, cyanosis, choking during the feeding. That is the tracheoesophageal fistula with continuous drooling of the saliva from the mouth. That is the laryngomalacia is the correct answer, and many of you have given the correct answer. Okay, so already discussed the question in the laryngomalacia. What happens when you will give the supine position? When you will give the supine position, that time the respiratory distress will increases, and that may lead to the cyanosis. Okay, hi, I will explain. And then when you will give the prone position, that time the respiratory distress will decreases and cyanosis will resolve and body become pink and normal. Right? Sir, why this is happening like this? Let me explain first what is the laryngomalacia. Laryngo means that is the larynx. Malacia means softening. In the newborn babies, the laryngeal muscles is not fully mature and which is very soft in nature. When you will give the supine position to the baby in the laryngomalacia, there is a highest chance of the fallback of the larynx on the trachea, and the larynx will block the trachea in the supine position. Similarly, when you will give the prone position, okay, the larynx will come out of the tracheal pipe opening, and which will opens the trachea. Means so during the supine position, the larynx is blocking the trachea, and during the prone position, the larynx going away from the trachea, which making the, yes, the pink body and decreased respiratory distress. So that will be seen in the very important in case of the laryngomalacia. Hope it is clear. So let me quickly revise all the golden points on the laryngomalacia. So this is the most common cause for the congenital stridor. Okay, if the stridor sound is coming, the most common cause for the congenital stridor is the our laryngomalacia. Okay, so usually in the infants we will see this one, and due to the immature muscles of the our laryngeal supraglottic structures. Okay, so which is caused by the floppy immature supraglottic laryngeal structure. Okay, that collapse inward during the inspiration and causing the airway to get obstructed. Okay, so when we give the supine position, okay, it will block the trachea, and when the baby will try to inspire, so it will move inward into the trachea, and which blocks the trachea. This is how, that is how during the supine position the baby will get the cyanosis. Okay, so stridor is inspiratory and worsens with feeding, crying, and supine position. Okay, so stridor is increasing due to the crying, due to the supine position, and due to the feeding. And when we will give the prone position, when the baby is in the cool calm and in the prone position, the stridor will get decreases. So that is classically seen in case of the laryngomalacia. So this is the very very important and easy concept on the laryngomalacia. This is only the scenario based and the very important concept will be asked from here. So do remember this one, give the best shot in your exams. Okay, so hope it is clear to you all. And here's the next question waiting for your response. A 4-year-old child presents with a high fever, drooling, stridor, prefers to sit and leaning forward with the neck extended and the jaw thrust forward. What is the this position is called? What happened here? There is a child with the age of the 4 year. Now the child is having the high grade fever. Continuously drooling of the saliva is there, and stridor is there. The stridor is there means something which is wrong with the upper airway. Okay, and presents with a sit and leaning forward. Okay, so the child prefers to sit only and child prefers to lean forward like this. Okay, and the neck is extended and jaw forwarded. Okay, so what the child is doing here, the child is trying to do opening the airway which is blocked due to the inflamed epiglottis. Okay, so in the case of the acute epiglottitis, the epiglottis is a, yes, the traffic police of the our respiratory system. Okay, so all of you know, I think so. Yes, this is the esophagus and this is the trachea. Here we are having the particular, what we can say, epiglottis on the trachea. Okay, so which closes the trachea during the swallowing and which opens the trachea during the inhalation of the air. Okay, right, so this is the, what we can say, the epiglottis. This is the elastic cartilage structure which is present as a bypass area of the our respiratory system, and it will prevent the what we can say, aspiration of the gastric content also. Okay, so that is the epiglottis. So is there any infection and inflammation to the epiglottis? That is what we call as the epiglottitis. So there is infection and inflammation of the epiglottis, means the epiglottitis means the airway is blocking, means the upper airway is blocking. There is a classical sign, we will see the stridor. Okay, and due to this infection inflammation of the posterior pharynx, there is excessive salivation production which leads to drooling of the saliva continuously through the mouth. Okay, so here the child is trying to move the leg, move the face forward and the jaw forward in order to try to open the airway. So that is what we call as the tripod position. Okay, so many of you have given the correct answer. There is a tripod position where child assumes automatically in case of the acute epiglottitis. So there are the golden questions which will repeatedly strikes in your exams on the acute epiglottitis. Consider this one as in the 10-star question. Okay, so there may be a chance of the coming the question with same option with or else with the same concept what I am explaining now on the acute epiglottitis. Okay, so comes here, but so acute epiglottitis is a life threatening condition. Why it is life threatening condition? Which is blocking our very basic need, means which is blocking the air entry into the our particular lungs. So there is block in the respiratory system, means which may threats the our life. Okay, so that is what we can say, which is the acute epiglottitis is the life threatening emergency which is caused by the inflammation of the epiglottis and leading to the airway obstruction. So that is what we call this one as in the medical emergency, or we can say the life threatening emergency. Okay, so most common cause in the pre-vaccination era. Okay, before the vaccination era, so that time there is a hemophilus influenza was the most common cause. Now hemophilus influenza is not a most common cause. Now we are giving the vaccine against the hemophilus influenza in our national schedule, national immunization schedule. The incidence of this particular acute epiglottitis because of the hemophilus influenza is reduced. Okay, so now the hemophilus influenza not in most common cause. Okay, so it is most common cause before the vaccination era. Okay, so now the most common cause of the our acute epiglottitis is the bacterial cause, that is the streptococcus pneumonia is the most common bacteria which is responsible for the acute epiglottitis. Okay, so this is the most very important question for you all. Okay, the next very important classical triad in the acute epiglottitis you will find is the high grade fever will be there, drooling will be there, and stridor will be there. Means the upper airway obstruction, drooling of the saliva with high grade fever. So we will see in the case of the our acute epiglottitis. Along with this, the 5D sign will also will seen in the acute epiglottitis. In the acute epiglottitis, we will see the 5D sign also. I will explain that one also. Don't worry. Okay. So here, due to the blockage of the airway, the child will typically appears toxic and he will sit in a tripod position. Means the child will try to lean forward. Okay, so the child is not sitting straight. The child is started to lean forward and he extended the neck and he started to moving the jaw forward here. Okay, so the he started to moving the jaw forward. So this is what you call as in the tripod position. Okay, which will be classically seen in the case of the acute epiglottitis. Okay, so in case of the acute epiglottitis, never ever, means one more classical sign will come. There is the hot potato mushy voice. Okay, hot potato mushy voice will be seen in the again in the acute epiglottitis. And so one important nursing intervention what we have to install here is to not to attempt to see the posterior pharynx. Okay, so do not attempt to see the posterior pharynx without any airway protection, because if we are stimulating the posterior pharynx, means there is chance of the spasm of the trachea due to the irritation will be there in the acute epiglottitis. Never ever try to watch and visualize the posterior pharynx in case of the acute epiglottitis. The most important for you all. Okay, so then the classically, the thumb sign we'll see in the lateral neck X-ray. Already we have discussed in the portion of the neck X-ray on this one in detail. Okay, so hope it is clear to every one of you on the acute epiglottitis. And the one more very important question, that is the 5D sign. 5D sign. Okay, so that is the dysphagia, means difficulty in the swallowing, the continuous drooling of the saliva, and the respiratory distress. And there is the difficulty in the speaking, that is the dysphonia and dyspnea, difficulty in the respiration. So all these 5Ds will be classically seen in which characteristic picture of the which of the following disease? Yes, option A, barking cough. Barking cough is a classical seen in case of the cough. Okay, so already discussed the most common cause is the parainfluenza virus for the cough. Okay, so that is not our correct answer. So I'm eliminating option A. Then comes to the asthma. In the asthma, there is an inspiratory. Yes, wheezing sound will be there. Okay, not any like this drooling distress will not be available. Distress may happens, dyspnea also may happens, but drooling is not available, and difficulty in swallowing also not present in the asthma. So I am eliminating the option D also. Then comes to the foreign body aspiration, so which based on the extent of the foreign body, how much it obstructed the airway. Many times there is in the like choking will be there, coughing will be there, sinuses will be there in the upper respiratory tract foreign body obstruction, but dysphagia, drooling distress, dyspnea, and dysphonia will be seen classically as the 5D sign in the acute epiglottitis. Again, so most important because of the upper airway obstruction and because of the irritation of the our epiglottis, there is a continuously problem in the swallowing. Okay, that is the very important. Hope it is clear to all of you, right? So yes, I think it's clear to every one of you. Okay, so here is the next question for you and waiting for your response here. Yes, already discussed question, bacho. The classical scenario. The newborn develops the coughing, choking, sinuses immediately after the breastfeeding. Okay. So during or immediately after the breastfeeding, what happening? The child is started to coughing, choking, and sinuses. An nasogastric tube cannot pass into the stomach, and which is likely. What is the likely diagnosis? Yes. Option A, congenital diaphragmatic hernia. So this is not our correct answer. In this one, due to the immature hiatal opening, the entire content of the stomach will comes into the chest. Okay, when we will auscultate the respiratory or the chest area, here we will see the bowel sound in the thoracic area. Okay, so in the thoracic area we are getting the bowel sound, means there is a classical symptom of the congenital diaphragmatic hernia. In the congenital diaphragmatic hernia, if the baby born with this one, the ambu bag is contraindicated. Okay, the ambu bag is contraindicated, means the bag mask ventilation is contraindicated in the, or we can say bag mask ventilation, which is contraindicated in the congenital diaphragmatic hernia. The most important question and concept for you people. Okay, so just previously only I have discussed if the a person or sorry, if the newborn is facing the coughing, choking, sinuses during or immediately after the feeding, and when we will try to insert, consider this one is the trachea, this one is the esophagus, and here is the what we can say, this is the esophagus and this one is the trachea consider. Okay, so this is the the lungs here. Okay, so the tracheoesophageal fistula is here and esophageal atresia is here, right? So when we will try to insert the NG tube, it will not go into the stomach because this is here is the atresia. Okay, so it will start to coil here. Okay, along with that one, when we will feed the baby, the milk will come here. The milk will come here into the esophagus. It will start to fill the esophagus, and when it will start to fill, the milk will start going into the respiratory tract. That time the coughing will happen. That time the choking will happen. That time the sinuses will happen. Okay, so the coughing, choking, sinuses during the feeding, which is a classically seen in the case of the tracheoesophageal fistula with esophageal atresia. Okay, and NG tube is not passing into the stomach. Okay, which is passing half and coiling here. So that is also classically seen in the tracheoesophageal fistula with esophageal atresia. The most important question for you people, right? Hope it is clear to everyone. I think so. So here is the next question. Waiting for your response in the comment box. बच्चों फटाफट try to mention the proper perfect answer. Yes, a full-term baby born via cesarean section presents with the tachypnea shortly after the birth. What happened here? The full-term perfect baby is there, but he is delivered through the cesarean section. He is delivered through the cesarean section, not by the normal vaginal delivery. Okay, so he presents with the tachypnea shortly after the birth. Okay, after shortly after the birth, the baby started for the tachypnea, and oxygen saturation is stable only. Okay, there is no any impairment in the oxygen saturation. Chest X-ray shows the fluid in the intralobular fissure. Chest X-ray showing the fluid in the intralobular fissure, and prominent pulmonary vasculature is there. Means when you will see the pulmonary vessels and vasculature, which is looking very prominent. Okay, what is the most likely diagnosis? Whenever there is any history of the cesarean section and tachypnea after birth and fluid in the lungs or in the fluid in the interlobular space in the lungs in the chest X-ray. So this is the classically seen in case of the transient tachypnea of the newborn. What it means, sir? The transient means it is for a short duration of the time and which is reversible and no need of the any acute treatment here. Okay, so the tachypnea means increased respiratory rate which happening in the newborn. But so what happens in the normal vaginal delivery? There is a surge called as the epinephrine surge, right? So this epinephrine surge, it clears the entire fluid from the lungs of the baby. Normally, in the baby when they are in the intrauterine life, there is the lung which is completely filled with the fluid normally. Okay, so during the normal vaginal delivery, the epinephrine surge makes the lungs to completely clear. Okay, if the baby is born with the normal vaginal delivery, the lungs are clear and there is no any transient tachypnea of newborn. But if in case the baby is born with a cesarean section or by the LSCS, what we can say here, there is no any epinephrine surge. No epinephrine surge means no clearance of the fluid from the lungs. Okay, no clearance of fluid from the lungs. Okay, so in the lungs the fluid will be there. So because of that, for the short duration, the transient means for the short duration, the increased respiratory rate, that is the tachypnea happening in the newborn, that is what we call as the transient tachypnea of the newborn. We will see with the history of the cesarean section and fluid in the lungs. Okay, so no clearance means completely accumulation of the fluid in the lungs. Okay, with a vascular prominence in the X-ray. Okay, so that is what you call as the transient tachypnea of the newborn. Very important for you people. Okay, consider this one for the 10-star question again. Very important. Okay, so hope it is clear to you people. Then comes to the RDS, meconium aspiration syndrome and transient tachypnea of newborn. Bacho, when they will create a scenario, consider here they have given there's the baby's full term baby. Okay, so with that one also we can consider the clue. Okay, if there is any tachypnea or increased respiratory problem or increased respiratory rate here, So we have to see the age of the baby first. If age of the baby is means age of the gestation when the baby is born, if the baby is preterm, if the baby is preterm, means the lungs are completely immature due to the lack of the surfactant fluid. So there the chance may have the respiratory distress syndrome, the RDS may happens here. Okay, so the respiratory distress syndrome is the most common cause of the tachypnea in the newborn. Okay, so if the baby is term, means he born at the proper time with the lower segment cesarean section, okay, with the LSCS history, term, with a cesarean section or the LSCS history of the LSCS. Okay, and there is tachypnea, means there is a cause of the transient tachypnea of the newborn. And if the baby is post-term, means born after the 42 week of the gestation. Okay, the baby is post-term. If the tachypnea is happening, means there is highest chance of the meconium aspiration syndrome. Okay, with the age of the baby also we can identify. So there is the preterm respiratory distress syndrome, term transient tachypnea of newborn, post-term meconium aspiration syndrome. Okay, so the most important thing, let me quickly revise the golden point on the transient tachypnea of newborn. There is no any treatment required, which will be normally resolves within the 72 hours. Okay, the most common cause of the early respiratory distress syndrome in the term. Yes, in the term we have discussed the early respiratory distress in the term happens due to the transient tachypnea of the newborn. In the preterm due to the respiratory distress syndrome. In the postterm due to the meconium aspiration syndrome. Okay, so that one we have discussed. Then caused by the delayed absorption of the fetal lung fluid due to the lack of the epinephrine surge. Okay, so in the cesarean section cases. Okay, if the baby born with a normal vaginal delivery, there is no any transient tachypnea of newborn. If the baby is born with a cesarean section, there is no epinephrine surge. There is no epinephrine surge, means there is no clearance of the fluid from the lung, means accumulation of the lungs fluid in the lungs remains same. So the baby may experience the transient tachypnea of the newborn after the birth. Okay, so then the commonly after the elective cesarean section it will happens. Okay, so if there is no normal labor process, okay, there is in the directly elective cesarean section if the mother is undergoing, this case will happens due to the lack of the epinephrine surge I have explained to you people. Okay, so then comes to the like it presents with the tachypnea shortly after the birth, and usually within 2 hours it will manifest. Then in the X-ray we will see the prominent vascular marking and fluid in the interlobular fissures. Okay, so which is self-limiting. There is no need of the treatment, which resolves within the 24 to 72 hours of the supportive care. Okay, when we will give a supportive care, like we will continuously monitor. So then we will continuously give support to the baby. So that time it will recovers spontaneously. Okay, there is no need of the treatment. Hope the today's session is very much enjoyable and clear to you people. And so in the tomorrow's class again we will discuss the very important hot and high yield questions, very important questions and topic for your upcoming exams again. Okay, so this is the assignment. Take a screenshot and make a best comment in the comment box with a question number A. Red currant jelly stool will be seen in which case, and strawberry color vision will be seen in which case, spoon shaped nail will be seen in which case. So I'm waiting for your answer in the comment box at the end of this class. Okay, so who all are actively participated in the today's class, you people have learned best thing in the competitive era. Okay, so this keeps you away and out of the crowd in the selection list. Okay, so that is the how we have to learn the actually thing by differentiating the actual clinical pictures which will ask in the exams. Okay, so all the possible things which will come in your exams I have explained in detail perfectly. Hope you people have enjoyed the today's class. Okay, so and here is the Norcet 9 Navagraha test series plan for you people. So all the features I have explained, that live test will be there daily basis since morning 6 a.m. to the 11 p.m. at the night. That test will be live in the app. After that at the 11:30 p.m. we are giving the all India rank. Okay, so in the official YouTube, official Telegram channel and WhatsApp group and WhatsApp channels. So we do have Telegram group for you people for the normal questions and quiz discussion, and who are especially preferring for the KGMU GMCH and searching for the topic based important questions quiz. So we have discussing the all the topic based important questions quiz in our telegram group with the free of cost, okay, which is actually free. So if you want to become a free quiz part, so you can join the telegram group as well, okay. So if you want to be a part of this Norcet 9 best India's platform of the test series, so if you want to become a part of this one, download the master nursing classes app. I have given the link in the description box. So thank you so much for the everyone for your active participation in the today's class. Again, in the tomorrow's class, we will discuss and deal with the most important things, questions, concept. Okay, so stay connected, stay tuned, stay motivated, keep learning the good things and the very important things with the clinical correlation. So that will help you people for the best rank in the upcoming exam. So we will meet in the next class. Tab tak ke liye, Jai Hind, Jai Bharat, love you all, bye bye.